Extracorporeal membrane oxygenation (ECMO) is a critical complex intervention in the management of refractory cardiogenic shock and severe respiratory failure. Unlike VV-ECMO, which primarily provides respiratory support, veno-arterial ECMO provides complete cardiopulmonary bypass. This fundamentally alters the patient's native hemodynamics. Increased left ventricular afterload. The retrograde flow of oxygenated blood from the femoral artery cannula directly competes with the native left ventricle. This increases afterload, which can lead to left ventricular distension, increased wall stress, and pulmonary edema if the LV cannot open the aortic valve. The need for LV unloading. Because of increased afterload, VA ECMO is frequently paired with an LV unloading strategy, concurrent intra-aortic balloon pump, or impella, often termed ECMella or ECPella, or surgical vents is crucial to unload the left ventricle. Differential hypoxia, north-south syndrome. This occurs in peripheral VA ECMO when the native heart begins to recover function but the lungs are still failing. Example, severe ARDS combined with cardiogenic shock. The recovering LV pumps deoxygenated blood to the upper body, coronaries and brain, while the ECMO circuit supplies oxygenated blood to the lower body. Understanding the hemodynamics of VA ECMO requires shifting from standard physiological models to evaluating two parallel circulations competing within the same vascular bed. This transforms the cardiovascular system into a battle of physics between native heart and the centrifugal pump. The parallel pump physiology. In VA ECMO, the patient's total systemic perfusion is the sum of two independent flows. Cardiac output total is equal to native cardiac output plus ECMO flow. As the ECMO flow increases, it provides vital systemic perfusion but fundamentally alters the loading conditions of the native heart. Initiation of veno-arterial ECMO creates immediate and opposing effects on the right and left sides of the heart. RV preload is significantly decreased. Mechanism: blood is actively drained from the inferior vena cava and right atrium, bypassing the right heart. LV preload is variable or increased. Forward flow from right ventricle to pulmonary circulation drops. However, if the left ventricle cannot open the aortic valve against the ECMO pressure, blood pools, driving up end diastolic pressure, that is LV EDP. LV afterload is significantly increased. Continuous retrograde flow from the femoral arterial cannula forcefully opposes native left ventricular ejection, effectively clamping the aortic valve shut in severe shock. Systemic perfusion, increased or restored. Mean arterial pressure stabilizes, driven predominantly by the continuous flow of the ECMO circuit rather than pulsatile native ejection. One of the most critical concepts is that VA ECMO does not inherently rest the left ventricle. In fact, it can punish it because the pump dramatically increases afterload. A failing LV may cease to eject altogether. This leads to progressive LV distension, which we can quantify using the Laplace law for myocardial wall stress. Sigma is equal to P into R by 2H, where P is ventricular pressure, R is the ventricular radius, and H is wall thickness. As the LV distends, increasing R, against the high afterload, increasing P, myocardial wall stress skyrockets. This massively increases myocardial oxygen demand, defeating the goal of myocardial recovery, and can lead to stasis, thrombosis, and catastrophic pulmonary edema. This is the physiological rationale for concurrent LV unloading strategies such as impella or IABP. In peripheral VA ECMO, retrograde oxygenated blood from the ECMO circuit travels up the descending aorta and collides with anterograde blood ejected by the native LV. The point where these two flows meet is called the mixing cloud or watershed area. Two scenarios. Poor native function. The mixing cloud sits proximal to the aortic root. The entire body, including the coronaries and brain, receives fully oxygenated ECMO blood. Recovering native function. As the LV strengthens, it pushes the mixing cloud distally down the aortic arch. If the native lungs are severely failing, example severe pulmonary edema or ARDS, the recovering LV will eject highly deoxygenated blood into the proximal aorta. Because the mixing cloud is pushed distally, this deoxygenated blood supplies the coronary and cerebral circulation, while the lower body receives perfectly oxygenated ECMO blood. This creates differential hypoxia, Harlequin syndrome, a hallmark hemodynamic complication of peripheral VA ECMO.